Thanks, Tady, and I'd like to thank the Society for asking me to speak today about a subject that I had a lot to do with and something that I'm quite passionate about, and that's treating mesothelioma with immunotherapy. So just in the next 20 minutes or so, I just wanted to run over some things with you. I guess firstly explain, well, what is it? What's it all about? Why is it becoming important? How does it work? And obviously there's a bit of hype at the moment about immunotherapy. What's behind the hype? And just at the end to speak about, well, where might we be in the future, in the next 5 or 10 years? So now the boring bit, we've got to talk about cancer cells. And I suppose we can't talk about treatment unless we really go back to talk about the basics of how cancer operates. So a cancer cell, like any other cell, is a bag of fluid on the outside. It's got a wall, a membrane, and that membrane is what presents itself to the outside world and the immune system. And deep inside the bag of fluid is... Oops, sorry. Not sure how to operate the... What does that do? Anyway, on the picture on the left, the nucleus is the genetic material, and that genetic material encodes for certain proteins which all have a function within the cell. The tricky thing about treating cancer is that genetic material is not the same as the normal cell from which the cancer was derived. It undergoes changes or mutations, and they continue to alter during the lifetime of the cancer. So on the right-hand side, what that's showing us is all of the possible proteins that can be encoded for by the genetic material. Some of the proteins don't do anything very important, and some of them are critical in terms of working out the process of how the cancer cell derives. As you can see from that spaghetti there, it's a very complicated process. And on the left, the other thing to say is that the growth process of cancer cells is very disordered, it's very chaotic. With normal cells, each cell will divide in two, and those cells are pretty much a carbon copy, a replica of the cells from which it was derived. But in cancer, it continues to undergo changes. And so as the cancer evolves, the cells look a lot different and more chaotic than from the cell from where they originated from. So, like in any trade, we've got tools. As an oncologist, we've got three main tools. We've got chemotherapy, we've got what's called targeted therapy, and we've got now immunotherapy. So Tady mentioned Alimta or pemetrexed, which is a chemotherapy that was approved in this country about 16 years ago now. Over the last 16 years, we've still been using the same drugs. So it hasn't really been a great success in terms of development up until now. What I wanted to show you is that on the blue graph, where it says time to progression, for the best chemotherapy, even in the patients where the chemotherapy works, within, on average, 6 months, the mesothelioma will start to progress again. So we've certainly got a lot of room to improve. I mentioned about the tools of the trade, targeted therapy. So what that's all about is to try and go into the genetics of the cancer, to try and find the genetic codes that are important for stimulating the cancer to grow, and to see if we can find drugs that might flick the switch to stop the cancer cells growing. That's a list of, not an exhaustive list, but it's a long list of all of the different types of targeted therapies that have been investigated in treating mesothelioma. Unfortunately, most of them have been very disappointing. And I think the reason being is, as I said, the cancer's continuing to evolve. So medication can't halt the traffic for too long. Just as the highway gets jammed up, if there's a block at one point, the cancer's going to go off a different exit ramp and carry on its way. So medication, I don't think by itself is not the answer. The immune system. Well, there's a lot of talk in the news about the immune system now, isn't there, with COVID? And the process with which the immune system deals with cancer in many ways is similar with how it deals with a virus. The key point is what's called a T cell. It's a type of white cell. Really refer to it as the soldier of the immune system. As you can see on the left there, a T cell has to be activated. It's got to be made angry towards a particular antigen. Now, that antigen could be a virus, or what we're interested in, it could be an antigen or a protein from a cancer. What has to happen is that a particular type of cell called the antigen-presenting cell takes that protein and presents it to the T cell and winds them up, gets them activated and angry against that particular protein. And we know that's important because just one or two dendritic cells or antigen-presenting cells, when they're wind up, they can create hundreds or millions of these T cells that can work on the thing they're trying to get rid of. A lot of things in the body have very tight controls. There's brakes and accelerators, and the same thing happens with the immune system. If our immune system was always on stop, then we wouldn't last very long in this world because there's a lot of viruses, there's a lot of bacteria. So we need our immune system to be functional when we need it to be. But on the other hand, if the immune system was switched on too much all of the time, the immune system could attack our own bodies. And you might have heard of what are called autoimmune diseases like rheumatoid arthritis. And so what we really need is to have that right balance when the brake's applied, when the accelerator's applied. This cartoon's showing us that certainly with dealing with cancer in the immune system, there are parts of the immune system that help take the brake off, and then there are also parts of the immune system which gear it up. And of course, what we want to gear it up against the cancer to cause the tumour to regress or to shrink. This cartoon just shows in basic terms some of the ways that investigators have looked at trying to deal with mesothelioma. We're going to be talking about the immune checkpoint blockade, going to be talking about neoantigen-based vaccines, and we'll talk a little bit about CAR T cells. So checkpoint Charlie, let's remember that was the block between East and West Berlin. So the checkpoint was a point that stopped traffic. We know that if it was very simple, then our immune system should be able to deal with any cancer that it comes across. The difficulty is that many tumour cells create checkpoints that stop these particular T cells from trying to deal with the cancer. And you'll see in the red boxes there's two of those proteins, the CTLA4 and PD-1. So essentially, the cancer cell, by keeping the immune system cell away, can continue to grow. So one of the main breakthroughs in research for immunotherapy was the development of what are called checkpoint inhibitors. So these are drugs that take that checkpoint, that blockade away, and then allow the immune system to recognise the cancer as being something foreign. So it's been described perhaps as taking the veil off the cancer cell to allow the immune system cell to recognise it. So the types of immunotherapy that we have at the moment, firstly is checkpoint inhibitors, and these are now off-the-shelf drugs that we can use to treat many different types of cancers. What they are, they're actually antibodies that have been designed to block those checkpoint proteins. So you'll see there PD-1, PD-L1 and CTLA4. Dendritic cell vaccines are a way to try and make those dendritic cells, the antigen-presenting cells, hyperactive. And CAR T cell is really now the ultimate in technology, really, to take these T cells out of the patient, to supercharge them against the mesothelioma, and then to inject them back in. So we'll talk a little bit more about the checkpoint inhibitors. So Ipilimumab, or Yervoy, is now licensed in Australia for the treatment of mesothelioma in combination with nivolumab or Opdivo. Pembrolizumab or Keytruda has been around for quite a long time, but at the moment is not licensed in Australia for mesothelioma. And the last one, durvalumab, is being used in clinical studies. So these checkpoint inhibitors are given intravenously. They're put in through an IV as an outpatient in a day centre in a hospital, usually given over about 2 hours. Patient has the treatment and goes home again. But before we talk about the benefits, we've got to talk about how do we measure the benefits of these treatments. So in oncology, there's specific ways that we describe that. The first one is the response rate, which means basically if you have 100 patients in a room and they all receive the treatment for that particular cancer, what number or what percentage of them do they get some shrinkage of their cancer? The other way is to look at what's called the survival rate. So you draw a line in the sand, perhaps at 1 year or at 2 years, and you see, well, what proportion of people are still alive or have their cancer and it hasn't progressed. And the other way to look at it is the average life expectancy for a group of patients with a specific treatment. So what we know about the checkpoint inhibitors by themselves is that the response rate, or the number of people where the tumour shrinks, hasn't really been that remarkable. So if you look at those, somewhere between 10 to 30% of people only does the cancer shrink. However, the point is that if you're in that group, the benefit lasts a long time. So remember how I said with chemotherapy, on average, it might be 6 months. It could be 18 months if you have a benefit from some of these drugs. And then, of course, if one's good, maybe two's better. And so people have looked at a combination of immunotherapy drugs. And when those two treatment arms have been compared, there's certainly an advantage for using 2 types of checkpoint inhibitors over one. And that's what led us to a very exciting trial that was presented last year, which I think has really changed the face of how we treat mesothelioma. And that's a trial called the Checkmate 743 study. So what they did in the study is all these patients had a new diagnosis of mesothelioma. Half of them received standard chemotherapy. The other half received immunotherapy with 2 drugs, and that immunotherapy could continue on for up to 2 years as long as they kept checking and ensuring that the treatment was at least holding the disease and the side effects were acceptable. And what they found, that there was an advantage in having immunotherapy, no chemotherapy at all. It reduced the risk of death by about 25%. Now you might say, well, that's so what? The difference is that over all of these years, the last 20 years, we haven't had any improvement over standard chemotherapy. And this is a combination of treatment that involves no chemotherapy or other targeted therapy at all. You're probably not going to see that very well, but many of you may know that there are different types of mesothelioma. It's a type called sarcomatoid and a type called epithelioid. The upshot of the results, when they looked at the chemotherapy versus immunotherapy, there was a much stronger benefit for the sarcomatoid type, which tends to be a more aggressive type of mesothelioma. The benefit was less for the epithelioid, but nevertheless there was an advantage for it over chemotherapy. The other thing is that the benefit in the patients who responded to immunotherapy, their benefit lasted much longer than for chemotherapy. And on the right-hand side, what they did in the study was to try and measure patients' symptoms. Looking at scans is one thing, but the patient's really the most important in terms of, well, how are they feeling? So they looked at their symptoms such as chest pain, breathlessness, loss of appetite, cough. And they found that the patients who had immunotherapy, there was a much longer time till those sorts of symptoms got worse. You're not going to be able to read much of that, but that's a list of all the side effects from each arm, chemotherapy versus immunotherapy. There were no surprises really in the chemotherapy arm. Nausea, risk of infections, constipation, feeling fatigued, off your food. In the immunotherapy arm, they didn't get those types of side effects. The side effects occurred in the setting where the immune system started to do something to the patient's own body. Commonly, that's a rash. Some people get muscle pain, some people get diarrhoea. But generally, we can manage those side effects and we can switch them off. So where are we with the double immunotherapy? Now I would say it's the gold standard treatment. That's the first line therapy for mesothelioma. As Tady said, on the 1st of July, it's now on the pharmaceutical benefits scheme. So the drug is provided by the government. It can be given in any public or private hospital. I've said it can be used instead of chemo first-line treatment, and it should be used as first-line treatment, but it can also be used for patients who've had chemotherapy before. The other question that's been asked is, well, how does chemotherapy and immunotherapy fit in? So there was an Australian-led study called the DREAM study, and what this study looked at were a group of patients who've just had a diagnosis of mesothelioma, and they all received chemotherapy and an immune therapy, a checkpoint inhibitor drug called durvalumab. And what they found is that nearly 60% of the patients at the 6-month mark in that group, they had no sign of progression of their cancer. I should say that that's a very similar result to the double immunotherapy from the checkmate arm. And as a result, a new trial has opened up called the DREAMer study. And this is what's called a phase 3 study. 2/3 of the patients receive chemotherapy and the immunotherapy drug, and 1/3 receive chemotherapy. I think the only downside with that really is that all patients receive chemotherapy. In my mind, now that we know where we're at with immunotherapy, perhaps it's not the right question. Perhaps the question is, well, does chemo add something to immunotherapy and not the other way around? This is a study that my colleague Andrew Nicol and I were involved in a few years ago, very generously sponsored by the Asbestos Disease Support Society, and we presented this at a meeting a couple of years ago. What we were looking at was the dendritic cell vaccine in combination with chemotherapy. We know that chemotherapy can have a role on the immune system, not so much as to suppress it, which is what a lot of people feel is the general thrust of it, but in fact it can take the brake off the immune system. So it may help immunotherapy. And we talked about dendritic cells before. Creating the vaccine is a fairly complicated process, and that's why it was an expensive process, and we were very fortunate that the Society sponsored this trial. First thing, we have to take a biopsy, and that can be difficult if people have already had surgery. Secondly, we have to put the patient on a machine where we collect some blood out of their arm, and that way we collect the dendritic cells. The next step is we take the tumour and the dendritic cells, and they put some scientific hocus pocus in there, some growth factors that stimulate the dendritic cells, and we put it in with the tumour to make the dendritic cells recognise the mesothelioma, and then we inject it back into the patient underneath the skin. And the idea of the trial was to see, okay, well, could we do it? Was it safe? Was it feasible to do? Could we get some idea as to whether this might be a useful process? Meaning, would it improve the outcome of patients with mesothelioma? And to see, if we could, whether doing the vaccine during chemo or after chemotherapy would be of benefit. So I won't bore you with all the details there, but there were 3 groups of patients. The first one, we gave the vaccine during chemo. The second, they had chemo, then as soon as they finished, we gave them the vaccine. And the third group, they'd had chemotherapy some time before, and we started the vaccine at a later stage. So we had 17 patients on the trial. To make the vaccine at that stage, it cost somewhere around about $10,000 to manufacture the vaccine. So even that relatively small number of patients created quite a bill. And what we concluded is that it was very feasible and a very safe thing to do. Sometimes it was difficult to get a biopsy, and 10% of the patients we couldn't safely take another piece of the tumour for various reasons. It can be safely given during or after chemotherapy. And when we looked at some other groups of patients in the same setting, there appeared to be, for a group of patients, a significant benefit. So we had some patients who lived an extra 3.5 years after having the vaccine, much longer than we would have anticipated. So I think, well, I'll come back to that, but I think there's probably some more room to look at that in more detail. And the last thing I wanted to speak about was CAR T cells, or chimeric antigen receptor T cells. This is a treatment now that's been used to treat many types of recurrent blood cancers, so leukemia, lymphoma. It's a very expensive treatment. It's starting to be used in the capital cities in Australia. It costs about $350,000 or $400,000 per patient to have it. And so this is what's called a phase 1 trial, which is being done in New York. Again, like our vaccine study, the patient has to go on a machine to collect blood, and they extract these T cells, which are those soldier cells we spoke about. And they're engineered in the laboratory against a protein called mesothelin, which is a protein that sits on the surface of the cancer cell. And what they're doing in this study is they're actually putting a catheter into the chest. So all these patients had mesothelioma in their chest cavity, and they put the T cells in there and they give them a dose of chemotherapy before they do that to try and take the brake off the immune system. So we'll wait and see where that goes. I think there's going to be some merit in it. It certainly sounds a fairly complicated, labour-intensive treatment. So just lastly, where might we be in the future? Well, I think immunotherapy is here to stay. I think the critical thing is we've got to try and work out for which patients is immunotherapy by itself going to be the best treatment. And there's a lot of brains around the world trying to work that out. If we can work that out, then perhaps we can tailor the treatment. Maybe there's some patients who need chemotherapy with their immunotherapy to take that break off, as I said. Perhaps some of the patients need the dendritic cell vaccine to really swoop up to try and get those T cells going again. I'm sure, as in all things, the technology will improve with the CAR T cells. It will get cheaper. It'll probably be eventually something that we'll be able to do in every hospital or clinic around the world. If we can do that, I think that's going to be the best way forward. But at the end of the day, we also need to remember that immunotherapy is just that. It's using the patient's immune system to deal with the cancer. So we have to focus on trying to optimise that. Things like exercise, diet, trying to keep the patient well, trying to optimise their immune system. And there's a lot of information now about what's called the biome, which is all of the bacteria that we carry on ourselves, in our gut and on our skin. And there's some suggestion that if we can optimise that the immunotherapy will work better. So I'll stop there and happy to take some questions.
Do people go to New York? Do they do that?
Oh, not at the moment, they don't. But I think those trials, the phase 1 trial, is really trying to look at whether that treatment is feasible, how people will cope with it, and to try and work out how many of those CAR T cells need to be given. So it would involve probably some very frequent hospital visits and to be monitored very closely in the clinic at Memorial Sloan Kettering. So there would be people from around the US certainly travelling there, but not from overseas.
Dr. Horwood, I have a quick question for you, and then we got Peter up the back there, but just a quick question about vaccines.
Yeah.
So we've always said that the only cure for mesothelioma is prevention. Stop the exposure, you're not going to have mesothelioma. So with vaccine, could that be a prevention? And I know that in WA they had that study, 17-year study into Wittenoom workers, I think about 2,500 Wittenoom workers, were studied, and that's the blue asbestos mine in WA, were studied over a 17-year period, and they gave them, I believe, injections of vitamin A.
Yeah.
And they found that that did not prevent the incidence of mesothelioma. But as your vaccine work, is that possible that that could develop into something that could be given to someone, say, exposed to asbestos as a preventer?
Short answer is no. So it's really more to do with treating an already developed mesothelioma case. So yes, obviously in terms of treating cancer, prevention's always better than trying to work out the cure. So no, what this vaccine was about was trying to improve immunotherapy for an established case rather than prevention.
Yeah, Doctor. Look, first of all, no question's a dumb question, okay?
Exactly right.
What I want to ask, and something that I don't understand, is that people get cancer of the pancreas, people get mesothelioma, people get prostate,
Yeah.
ladies get their own issues with cancer. Is cancer the same thing, but it just gets different names because of what it attacks? Is it generally something that's inside of us, whether it be down there, up there, in your head,
Yeah.
the same thing?
That's not a dumb question. That's really gets to the nuts and bolts of what it's all about. So yes, so when we say someone's got pancreatic cancer, that's where it starts. But it can end up in the liver or it could end up in the lung. We still refer to it as pancreatic cancer. So that's been the traditional way. So we'd look up the book and go, oh, well, pancreatic cancer, we use this drug. There you go, bang. But we know that it's more involved than that, because if we look at the genetics in a cancer, whether it started in the pancreas or it started in the lung or whether it's mesothelioma, you could find the same sorts of genetic problem. So there is some discussion or move to refer to different cancers, not so much where they begin, which is, pretty basic, but to really refer to what's the defect in the DNA that's caused that problem. And then we use the same drug according to what the defect is. So meaning you could have the same drug if it fits that genetic problem, whether it's started wherever in the body.
Hello there. I want to know if all the oncologists have information about immunotherapy, because
They do now.
they do.
So just to backtrack a bit, so about middle of last year, when those results of that Checkmate trial, the big trial which showed Yervoy and Opdivo was better than chemo, when that came out, there was an access program. So we were able to get those drugs. Now, probably not everyone might have been aware that those drugs were available at that time. But as of the 1st of July, every oncologist in this country would have access and they would know about those drugs. And as I said, it doesn't have to be the first treatment. The patients may have had chemo before, like a year ago, and if the cancer's getting worse, they could now have that treatment.
Thanks. Going off Peter's about the different cancers, but mesothelioma is predominantly lung related. Has it mutated anywhere else?
Well, so mesothelioma, about 90% of the cases start in the pleura, so in the lining of the lung, and about 10% start in other locations. So in the lining of the tummy, it's called the peritoneum, which is the sac that all the gut fits in. And then there's also some other very rare places where it can begin. It's not common that it spreads to other parts of the body, unlike other cancers.
What are the deciding factors that makes an oncologist say, yes, this patient has chemo and immunotherapy, or just straight immunotherapy?
Well, up to this point, it's been largely what's available. So the DREAM study in some hospitals and some institutions, that was a trial that was being run. So, of course, that would be something that would be presented to the patient as an option. I think outside of a trial as of the 1st of July that the double immunotherapy would be what I'm sure majority of oncologists would present. So I think things have changed even within the last, well, we're in October now, so in the last 3.5 months.
When my husband died 11 years ago, he had excellent chest surgery, which gave him great relief, and so we were able to cope with the morphia drugs for that 12 months. It was exactly 12 months before he died. How long after that was the first chemo? You've been through so many, though.
So the chemotherapy, which is what you asked, was probably around about 2007, I think, from memory, 2006. Yeah, okay. So I suppose it might have, I mean, I can't speak on what the decisions were at that stage, but I suppose sometimes it depends. With chemotherapy, there are unfortunately still a number of side effects. So whoever the oncologist was that saw your husband, it would have been a discussion, I think, about side effects, how that would have affected his quality of life, what the benefits might have been. So there may have been a decision made in the sense that perhaps it was felt that the chemotherapy may not have been the best option for him, as it would have really made his quality of life worse, perhaps. And that's still something that up until recently we've had to seriously think about. And even with immunotherapy, it's possible that there may be patients that are even too unwell to have that.
Doctor, question just here.
If I'm on Premba, Keytruda, would you recommend to have 2 chemicals for the immunotherapy or just the one?
Definitely 2.
Definitely 2.
Yep. So I think whether it's the first-line treatment or after chemotherapy, 2 seems to be better than 1. And I think the reason is that the drugs work in slightly different way to take that veil off the cancer cell.
Okay.
So it seems that the double treatment is the best way forward.
Do most oncologists use 2 or just the one at the moment?
Well, as of the 1st of July, they used 2, but up until that point, me included, we would only really use 1 because essentially, because those drugs were not covered by the pharmaceutical benefits, by the PBS, the patient would have to pay. And these drugs are very expensive. So up until recently, most people would only have 1 of the drugs, like Keytruda or Opdivo.
Okay. Thank you.
Keith, just a question down here from Karen, who's the Society's support nurse.
With chemotherapy, sometimes it's stopped after a while and then it can be restarted. Is that the same with immunotherapy?
It can be. The difference is that with immunotherapy, firstly, it does allow itself to, because the side effects are generally much easier to tolerate, people can have immunotherapy on an ongoing basis. Number 2, that's what was done in the trial. So they tried to keep the immunotherapy going over a period of 2 years. And that's what's actually is being provided by the government on the PBS, 2 years of immunotherapy. So it can be stopped if there were, say, side effects or whatever, and can be restarted. But generally the idea is to try and keep it going for an extended period of time. That seems to get the most benefit out of it, or provide the most benefit.
Doc, one last question just from me. You mentioned 2 years, and you kind of answered the question that I was going to ask, but what happens after 2 years? The patient has to start paying.
Well, as it stands at the moment, yes, that would be the case. Now, obviously, we've only just started this system in July, so we've got another 21 months to go. I guess, firstly, we'd have to say, well, unfortunately, there's going to be a number of patients where they're not going to get to the 2 years for various reasons. But yes, there will be a proportion of people where they will get to the 2 years and the government will pull the ladder up. So I guess at that point it would be an issue of, so the possible options would be then to see, okay, well, perhaps from a compensation point of view, whether that could be built into funding for that ongoing treatment, whether the pharmaceutical company would come to the party to provide those drugs. That's probably going to get less and less an option, I think, now. But yes, it's an important question, and we don't know yet what will happen.
I think one more question.
Yeah.
How many times can you use the vaccine?
Did you say Avastin?
Vaccine.
Vaccine.
Oh,
How many
vaccine.
times
All
can
right.
you
Yep.
use a vaccine?
Okay. So when we did the trial, we were limited by how many vaccines that we could make. So what happens is when we collected the cells and we manufactured the vaccine in the laboratory, some patients made a lot of vaccine and some only made a small amount. It came down to the number of cells that we could collect. So it could be an ongoing basis. I mean, many of the patients were on the vaccine for over a year, given it, every initially 2 weeks and then every 4 weeks. You'd have to go back and do the whole process again to make more vaccine if you wanted to go further.
Thank you very much, Dr. Horwood. Would everyone show their appreciation for Dr. Horwood? Probably come on down. We've got a little gift for Dr. Horwood here. I hope he enjoys it.